All right, so hello everybody. My name is Miriam Weiss. I'm a young neurosurgeon working in Switzerland, and moderating this webinar with me today is Ana Hernandez Rodriguez from Barcelona, Spain. Our topic today will be new aspects of aneurysm treatment, and we have an exciting panel, 3 panelists that are going to speak today. Starting today is Nima Edminan, the chairman of the neurosurgical department in Mannheim, Germany. He has a long-standing record of aneurysm research, basically from the formation to the rupture to the consequences. And one of his goals is to harmonize treatment, standardize treatment, which is probably challenging, but really important. So we're excited about his talk on the ESO guideline today. Welcome, Nima. And then maybe you can just wait a second. Since Nima has to leave early, please post your questions in the QA box right during his talk. QA box is right at the bottom of the screen. And then we will have a plenary round in the end with the other 2 speakers. All right, please, Nima, go ahead.
Thank you, Miriam. Thank you, Silvia Hernandez, and also Anna for the kind invitation to talk about the 2023 ESO guidelines on management of unruptured intracranial aneurysms. By way of introduction, as you all know, the prevalence of unruptured intracranial aneurysms is quite high. It's estimated about 3%. But according to our upcoming meta-analysis on the prevalence of unruptured aneurysms, this is distinctly higher in certain risk groups, and even it goes up to 10% in patients with arteriosclerosis or female smokers. So as you all know, the Issuer study provided us some insights on the absolute risk of aneurysm rupture for the Caucasian population. There was the UCAS Japan study, which could be used for Japanese patients. But if we focus on Issuer as a European community, this study identified aneurysm size and location as the main risk factors. But ever since, we identified many more risk factors for rupture, for instance, aneurysm morphology, and also smoking or hypertension. And there's few data on risk factors for treatment. It should be noted that there is only one randomized controlled study that was published and completed and published for unruptured intracranial aneurysms, and I will speak about that. And you should note that the ISAT study and the ISAT data cannot be extrapolated to patients with unruptured intracranial aneurysms because that is a different disease. And additionally, ISAT cannot be used as a fundament for patient counseling for any devices other than coiling. So the 2013 guidelines that were published in cerebral vascular disease by Thorsten Steiner provided only minimal recommendations based on the rather scarce literature back then. And that was the impetus for our group to provide evidence-based recommendations or consensus-based statements where there was little evidence for important aspects of UIA management. So as I noted, there's only one randomized controlled study in a setting of unruptured intracranial aneurysms, and that is the CURE study, which was published by Tim Darceau and colleagues in 2023. And despite all the limitations in the design of that study, for instance, the choice of primary outcome, which was a composite due to the sample size, and the primary endpoint was failure to occlude the aneurysm with the allocated technique, so either endovascular or surgery. And these instances comprised failed aneurysm occlusion, meaning intracranial hemorrhage. During follow-up, I'm going to use this laser feature here so that you can see my pointer better. Is it better now? Yeah. A residual aneurysm and a failure to treat the aneurysm with the allocated modality. And secondary outcomes were of clinical nature. And regarding the primary endpoint, there was an absolute difference between surgery versus endovascular in favor of surgery, meaning that aneurysm treatment by means of microsurgery was the more definitive treatment strategy. However, it should also be noted that on a clinical scale using the MRS, there was no difference between the two treatment modalities at discharge and at 1 year follow-up. But there was a higher frequency of initial neurological deficits in the surgical group, which didn't translate into a long-lasting difference in MRS. And it should be noted that at 1 year follow-up, the rate of complete aneurysm occlusion was 80% versus 57% in the endovascular group, and that there was residual aneurysms in 8% of surgically treated aneurysms versus almost 60% in the endovascular group. So that is the best data that we currently have for counseling on patients with unruptured aneurysms based on a randomized controlled study. So if you think of the general setting where you advise patients with unruptured aneurysms, the first question is, however, not which modality, but rather to treat or not to treat. And we concluded here based on the evidence, which was a meta-analysis of the published data and an annual risk of rupture in the available literature of 0.8%, that aneurysms should be treated if the estimated 5-year risk of rupture is higher than the risk of preventive repair. And that is irrespective of the modality. And if we use this data, you can say that the risk of treatment is about 3%, and it's higher in more complex aneurysms or if more complex procedures should be needed. Regarding expert consensus, there were many additional factors that influence decision-making, and I'll provide you the link to the EASL guidelines at the end of my talk. But you should note that beyond aneurysm size and location, it's aneurysm lobulation, family history for UIAs or SAH, smoking, hypertension, and importantly, UIA growth during follow-up. And clinical symptoms such as cranial nerve deficits are an important indicator for treatment. In patients that have undergone aneurysm growth, there's good evidence from the Utrecht group that the risk of rupture in such patients is quite high, and we recommend treatment in patients that have recently shown aneurysm growth during follow-up, growth being increase in diameter by 1 millimeter in any direction. So then modality, and the conclusion was that we cannot make an overall recommendation for either of the modalities based on the available literature. Meta-analysis data suggested that the overall risk of UIA treatment is 1 to 6% for major morbidity and death. And that treatment failure, as I noted, is higher after endovascular aneurysm repair. And the frequency of a new neurological deficit at discharge is higher. That doesn't translate into a difference in MRS at 1 year. So that is the fundament for patient counseling for the standard setting, and then flow diversion as a primary treatment that is more frequently advised for patients. The evidence-based recommendation was that this should only be recommended as the primary option if there's no other endovascular, meaning coiling, or microsurgical options. to occlude the aneurysm because of the distinctly higher risk of flow diversion compared to coiling. And this was based on a meta-analysis of 110,000 patients, or nearly 110,000 patients and 110,000 aneurysms. And the absolute risk ratio for increase in risk was 3.5-fold or 3.3-fold. There was controversy in the community based on this recommendation, and we replied to this, and you're welcome to look at it. But just to conclude for now, I can summarize that for the time being, and we conducted a new meta-analysis that we will publish in a couple of weeks for the German guideline, that the risk of flow diversion is still higher than coiling, and sometimes also for clipping of bifurcation aneurysms, and the occlusion rates are yet not optimal. However, there's of course aneurysms that are best treated with flow diversion, and nobody argues that. The recommendation is if there's a better endovascular option, meaning coiling or surgery. So the expert statement for UIA decision-making in this setting was that this should be discussed in a multidisciplinary setting, and I think that is important because we see more and more patients that have only been to a neurosurgeon or only been to a neuroradiologist instead of a combined recommendation. And I think neurovascular centers usually discuss such cases in a board, and there it should be neutrally discussed for the individual aneurysm what the chances of complete occlusion are and the risk of complications. And I think it's important to talk about effectiveness and safety combined. Additionally, we see more and more centers that treat aneurysms, and I think most of us would agree that there should be a certain amount of volume that is managed at a specific center and a specific operator. And we defined 100 patients seen at a center with an ruptured or unruptured aneurysms per year, and 30 patients treated with an aneurysm per operator per year as the minimum. So just to finish this talk with a few illustrative cases, this was a 40-year-old or a 43-year-old male patient that had a family history for SAH, and was very scared to also have an SAH because his father died from this. He was a IT expert, and he went to 4 different places, and they recommended flow diversion for this quite large carotid terminus aneurysm, and he had hypertension and the family history as a risk factor. And when we advised him, we advised surgical clipping, and I will forward this video a little bit for time reasons, but you could do these cases using intraoperative monitoring. And yes, it's a bit of work, but if you have enough experience at your center, this is still a very good option. And here you will see at the back end of the aneurysm, the perforating artery. So we lower the blood pressure in these patients for 2 minutes to soften the aneurysm that you will see in a second. Here, the aneurysm is soft under blood pressure of 50 systolic. You can dissect the perforators from the back of the aneurysm, and then you can effectively clip this aneurysm as the definite treatment under intraoperative monitoring. And that I recommend in such cases because you can detect ischemia there easier and adjust your strategy. And you can appreciate that this aneurysm was completely clipped and the patient did fine. And there was no need for flow diversion and risking this A1 and jailing it, which most neuroradiologists that I know wouldn't do. The second case was this female patient, Ukrainian refugee who was with her son. She was about also in the mid-40s, came to our hospital on an emergent basis with a new seizure, and she had severe headaches and had this giant, I would argue, M1 aneurysm that incorporated also the lenticular striates, the lateral lenticular striates. And we discussed this strategy in this patient, and we deemed that flow diversion may be an option in this patient, but more riskful than a microsurgical approach. And in such cases, we aim for a trapping using a bypass strategy. And also for the sake of time, we did a STA proximal with radial artery interpositional graft. Here you can see the influx into the aneurysm. Here it is. The aneurysm is all of this here, and there's unfortunately a perforator right at the base of the M1, which is here. And you can appreciate the pressure on this aneurysm. So what we did was that we did a proximal STA anastomosis, and I do this with my colleague from plastics. And then we did a M2 bypass here with the radial artery graft. And we were even prepared to do, using this small side branch, a double barrel if we had to, from the radial artery. And I'm gonna fast forward this a little bit. So here we first do the bypass, and then we cut the flow into the aneurysm with the proximal clip, and we apply the distal clip to the outflow. And there we saw a drop in MEPs, and I removed the temporary clip. The temporary clip from the distal part of the aneurysm, because I thought it was reliable, and it was good that we did that, because the patient did have a lenticular striates arising from the aneurysm, and we only did proximal occlusion with the bypass. And she had a transient weakness for a couple of days and did well at the end. And yet the aneurysm was completely treated despite the only proximal occlusion. And I think that's an important strategy in such patients. And finally, what we often see, is of course such large proximal carotid aneurysms. And this patient was symptomatic with an incomplete cavernous sinus symptom. I think you can hear my kids singing in the background. Sorry. This patient was treated with flow diversion and partial coiling, and despite the flow diversion strategy, there was still ongoing filling, and our colleagues from neuroradiology asked us to do a definite solution, and here we did another high flow bypass using the external carotid to radial artery with an interposition graft to the M2. And I'm going to skip most of this, but this is here the proximal anastomosis. And what we did here was that you can see the high flow bypass from the external carotid here. And we then trapped the whole segment distal to the ophthalmic artery to not risk the vision of this patient. And we clipped the distal segment of the carotid at that site. And in this case, this was the best strategy, and it worked well. So to conclude, and this is the reference from the ESO guideline, the current evidence suggests that aneurysms should be treated preventively if the risk of rupture is higher than the risk of treatment. At present, there is no recommendation of clipping versus endovascular aneurysm repair, and it should be based on an individual patient and also center basis according to the operator's experience and according to the likelihood of treating the aneurysm completely and safely. Flow diversion for the time being, and this is also in an updated meta-analysis with a literature search from until a couple of months ago, is best performed when there's no better surgical or endovascular option. These are the minimal numbers. And you should consider radiological follow-up if treatment in the future remains an option, and treat a patient that displays aneurysm growth during follow-up. And finally, I have showed you a couple of controversial cases, of course, but I think at centers where there is an expertise for microsurgical cerebrovascular surgery, these cases are well managed, and this was an initiative by the ENS under the guidance of Victor Volovici and the chairs of the ENS vascular section, and I saw Marco Cenzato is also in the audience today, and a couple of high volume centers, including Mannheim and Berlin for Germany, to create centers of expertise where we could establish fellowships for colleagues in Europe that want to learn complex cerebrovascular surgery, but also to prospectively collect outcome data in such centers. Thank you very much for your attention and for the kind invitation, and I welcome your questions immediately now instead of later. Thank you.
Yeah, thank you, Nima, for this excellent presentation and for your work on this guideline. I think it's obvious that there are a lot of questions that we don't have really great evidence on right now, and it might become even more difficult in the future with all of these new endovascular methods that are coming up. Was that a problem in the current guideline making?
I think what was interesting was that there was a lot of harmony and consensus in the guideline group because most colleagues were experienced enough to acknowledge the shortcomings of their individual modalities, including the neurosurgeons. But of course, we had to make recommendations where there was little robust data. We talk a lot about safety and effectiveness, and I think Victor Volovici's paper in this respect that was published last year, I think it was last year in JAMA Open, showed that there's really a lack of data that supports statements like safety and effectiveness. So for the time being, we have little comparative studies, we have little IIT studies that provide us evidence. And I think there we still need to stick with the best data that we have, and that is for the time being cures.
Are there maybe a couple of trials that are ongoing that might change things in the future that you would have us look out for?
So I'm not aware of any non-industry sponsored RCTs. There's a lot of registries that are sponsored by the industry, but that is also a bit of a problem when investigators are also sponsored by their companies. So I think we need an IIT for instance, web at some point for bifurcation aneurysms. But I think most of us know that such trials are also difficult to sell to patients. And there's, of course, our own trial, Protect You, where there's 380 patients already randomized, that shows that the risk of rupture for the time being in these patients at 7 years follow-up is very, very low.
Mm. All right, so we do have a couple of questions in the chat, starting with what is the least systolic pressure that you implement during clipping?
So we go down, and the patients sometimes regulate against this. So you have to really talk to your anesthetist, and we have a great anesthesia team in Mannheim that is very experienced. So you can only do it sharp down 2 minutes, 50 systolic ideally, or 40, and then go back sharp up instead of a prolonged phase of hypotension. That is difficult. So
Nima,
50.
Do you always use the systolic pressure, or do you use temporal clipping when possible?
So I do temporary clipping, of course, as well, but we all know that even in experienced hands, there is perforator ischemia due to temporary clipping. And what I like about the hypotension, and we will publish this soon, is that it's a low flow situation instead of a no flow situation. And it gives you, it's just like rapid ventricular pacing, that it also lowers the blood pressure, but it's a bit more, I think, invasive. And we had a major complication when we did it in an undetected PFO. So I do like it. But of course, it's always based on the location. Proximal carotid can also have ischemic complications if you do prolonged temporary clipping there.
Yeah, right. And then we have two questions about radiological follow-up. What interval, and if it's CTA or DSA. Doesn't specify if it's for treated or untreated, but maybe you can give us a quick summary on both.
Yeah, so that was the most controversial topic, to be honest. It wasn't modality or clipping versus coiling, it was follow-up. So to cut it short, we have to do CTAs in clip patients, MRAs in endovascularly treated patients. There's the ELAPSE score that guides how to time intervals. That is the best evidence for the time being. I do it on an annual basis, and if there's stability, I prolong it to 2, 5, 10 years.
Now that you mentioned the score, I was wondering how much weight do scores in predicting growth or rupture or complications, how much weight do they have in deciding whether to treat an aneurysm or not in your department?
So we use phases. We also use UIATS sometimes. We use ELAPSE to plan follow-up. But of course, it's not the absolute truth. It's the basis for discussion. But if you have a 3-millimeter aneurysm in a patient that is not hypertensive, doesn't smoke, in a proximal carotid para-ophthalmic, the risk of rupture is 0.3% over 5 years. There's very solid data on that. And I think that helps to relativize fears in patients.
There's also a very interesting question from Dr. Sensato. Do you suggest any differences in the recommendations for surgical versus endovascular treatment of anterior communicating aneurysms compared to MCA aneurysms?
Yeah, again, Marco, that's a very good and important question. I think it's difficult to make an overall recommendation. We have a clip first strategy for MCA, and we have good outcomes. And for ACOM, if it's a forward pointing or downward pointing ACOM in a young patient that is broad neck and needs a lot of hardware, we would do clipping. If it's a posterior pointing ugly ACOM, I have no problem with a complex endovascular solution because they can also be difficult surgery. So I would argue based on morphology, projection, age of the patient, and not only based on location.
And do you use the same decision-making algorithm for rupture? for ACOM rupture? So could you also treat with clipping jam patients, forward pointing?
Yeah. Yeah.
Nice.
There's Michael is on the call.
Oh, nice.
Looks like it.
So Michael asked, and that's also an important question, in the setting of the same giant aneurysm, but in a ruptured situation. Well, I think a proximal occlusion is a difficult strategy if it's a ruptured aneurysm, and I'm not sure I would feel comfortable. And I don't think so. In this case, wasn't comfortable in aiming for clip strategy. So you could also, in such a patient, aim for in situ bypass, meaning a third or fourth generation bypass. What would your suggestion be? I cannot talk to you personally, but maybe you can reply in the chat.
Maybe while we wait for his answer, maybe one last question for you. It's more on the training aspect. You must have seen a lot of changes in training in vascular surgery over the last couple of 20 years, maybe. What would be your advice for young neurosurgeons wanting to go into that specialty? Go get endovascular practice. It's not that easy in Europe, as in the US, maybe not that easy to practice. Maybe Philippe can say something about that later as well. Yeah, what's your advice on that?
So I'm a bit biased, of course, because I only do the one thing, but I think it worked well for me, and I see still an increasing volume because we see a centralization of microsurgical aneurysm treatment just by nature of the centers. And my take on it is that I'd rather be good in one thing than average in two things. I'm not sure how others feel about this, but if you do this as a hybrid setting, then you can only do vascular and not do neuro-oncology, etc. And then you need a good volume. And I think there's centers that works for them. But my take is I personally develop my expertise based on a high amount of focus just on microsurgery.
Sounds reasonable. So we have Michael Lawton in the call now, I think, but it seems he's agreeing with your strategy on the giant aneurysm from the chat, right?
I even see him in the video.
Yeah, I'm here. Can you hear me?
Yes.
Yes.
Good to hear you.
Guys. Yeah, good to see you guys. I don't know why my video is not working, but anyway, great to see you. And yeah, no, it's a tough problem because I've been burned by just proximally occluding a ruptured giant aneurysm before. And on the flip side, you can't trap those lenticular strides, so you're kind of caught on both sides. So it's a tough problem that I haven't really solved unless you trap the thing, deflate it, see if you can get around and find those lenticular strides and find a way to exclude the rupture site, but still preserve the base of the M1 where the lenticular strides come out.
And so fortunately, I've never seen a ruptured M1 like this. But would you then do like a Y construct if you don't have a clip strategy?
Well, your bypass is fine. You can't bypass those lenticular strides. So you've supplied your distal MCA territory adequately. So there's really not a problem on the bypass side. It's a problem on the perforator preservation site.
Proximal perforators, yeah, I agree.
Yeah, and sometimes those M1 aneurysms will push the lenticulostriate trunk proximally. Sometimes they'll push the trunk laterally or distally. And in those two settings, you can complete a trap and not compromise those perforators. But if they spread themselves along the base in the true dolichoectatic type aneurysm, then you're kind of hosed.
Yeah. So in this case, I was really fortunate to have intraoperative monitoring. Otherwise, I would have trapped it, and then we would have had a major problem. So I think in this case, it was the best solution to do a proximal occlusion only.
All right. Thank you, Nima and Michael, for this great discussion. We do have more questions in the chat, but we do have to move on with our next speaker. Next speaker will be Roland Schwab. He's an interventional neuroradiologist from Magdeburg in Germany. And he will talk to us about aneurysms that incorporate perforators or side branches and in flow diversion in these aneurysms. Please, Roland.
Thank you, Miriam, for the invitation and the nice introduction. So I will go on because we run out of time. Just one short comment to you, Nima, to the talk. Thank you for the great summary, and you're absolutely right. It's an individual decision. We can't say everybody have to be clipped, everybody have to get an endovascular treatment. That's totally true. But just we should also take in future into account that there are possibilities for endosaccular flow disruption that is kind of coiling, so we don't need a double antiplatelet therapy and so on. And maybe that finds its way in the next guidelines. I think that could be some solution for some cases where then endovascular treatment is also an option.
I said, right, we need an RCT for that.
Yeah, sure.
That's exactly the thing.
In the future, we get some data that we can that it's find its way in its guideline, because it's a straightforward treatment and it seems to be safe and efficacious and straightforward. But we need more data. That's true. So I will go on. I was asked for talking a bit about treatment of complex cerebral aneurysms and the endovascular approach. Of course, I'm an interventional neuroradiologist here in the University Hospital in Magdeburg, Germany. And especially I was asked to talk a bit about, are these and those perforators at risk after flow diversion? Because I think that's an important question when we talk about flow diversion the intraluminal way. So first of all, we have to talk about what is a complex aneurysm. So what's the definition about that? You see here some cases. Here's just a bifurcation aneurysm. Then we see here another IK aneurysm, and we see a bilobulated complex aneurysm, what's so-called as complex, but are there any definitions out there? And everybody think, yeah, sure. Everybody knows what is a complex aneurysm, but it's not that easy to figure out what's really in complex aneurysms. There are some definitions out there. Ricardo Henel and Mr. Spetzler and also Mr. Pescatori in a review just tried to figure out what is a complex aneurysm. It was described as aneurysms, first of all, that got a diameter exceeding 25 millimeters, so these giant aneurysms. Then also if previous treatments or recurrence and incomplete closure is the case, and the location is at one point, if an aneurysm could be called as complex. Also, if the surrounding brain, the brainstem, the cranial nerves, and so on, should be compromised by the aneurysm, and also the absence of collateral circulation should be one point. Then that was described as also partial complete thrombosis of the aneurysm sac. This is another point, and also the next point, the calcification of the aneurysm wall should be described as complex aneurysms, a broad neck, branches arising from the aneurysm itself, parent artery, and the wall structure, if it's blister-like or it's a dissecting aneurysm. And of course, the morphology is one part of it. So you see, there are many ways how a complex aneurysm could be described. And you see here some images. You see here this this giant basilar aneurysm in the MRI, which compromises the brainstem, and also again this complex bilobulated ACOM aneurysm. So With this aneurysm then should be called as a complex aneurysm. That's the MRI run. Oh, I'm sorry. That's the MRI run of the aneurysm, what we saw on the slide before. Here's again the slides. And we described it, and also our neurosurgeons described it as a complex aneurysm. We treated those patients with a flow diverter. This was a pre-angio run. It was partial thrombosed, like you saw already in the MRI. And after direct the implantation of the flow diverter, there was some stagnation in the aneurysm. So it was a recent case. I did that one 2 days ago. So I don't got any follow-up pictures, but the patient was fine. He got no infarcts and is doing well. But let's go on. So we got different treatment options for different kind of aneurysms. And when we call them complex aneurysms, we can't use one procedure for all. Like I mentioned before, you also have to take into account the surgical approach and different endovascular approaches. So there are different tools in our box. We can do just a simple coiling. We can do a stand-assisted coiling, also balloon remodeling and the coiling, and of course the flow diversion, and that will be the main topic of my talk today. There are also different kind of stenting, and the more devices you use, the more complex the procedure will be. And it's also true that the complication rates arise as more devices you use. So we're focusing on flow diversion. I'll just give you now a brief introduction in flow diversion about the concept, and then I will focus on some points. It's more a technical talk. I think Philippe will then talk more about the practical approach. When we talk about flow diversion, the concept is that we redirect the flow of the aneurysm, and it's not just altering the inflow, so we alter also the outflow. So we want to reduce the in and the outflow. Also, these flow diverters providing a scaffold that the parent vessel can heal afterwards, and there are different kind of mechanism of the action for flow diversion. First stage is the hemodynamic stage, like you see here in the right side. So we reduce the in and outflow, like I mentioned before. Then we got the thrombus formation stage, where the thrombus will formate during this time after days and weeks. And on the long run, we've got the endothelialization of the parent vessel, and then is the vessel more or less healed. I don't want to prolong that, but we see here just a short animation from the Mayo Clinic. You see here the flow diversion is redirected, and we got this thrombus formation, and the aneurysm is cured after the endothelialization. So now the most important question is, when we just place a flow diverter, we always cover branches. We not ever see all of the branches, because some of the branches are so small, and these perforated branches, that we can't see them in the angiogram or in the Dyna CT or in any imaging modality. But every branch had tons of perforators and side branches that we don't see. So we always cover branches. What happens with them? Are they preserved? Are they occluded? Or are they even every time symptomatic if you cover them? So let's take a look at the literature. There were, until now recently, many of the studies that focus on different branches and territories that are covered. Here's just an overview which branch should be covered. When we see here, this was an work from Stuttgart under the guidance of Hans Henkes, and we see here there were overall 20% occlusions of the covered branches. But when we take a special look at the anterior corridor artery, that's really interesting. There were 91 branches covered, and we had no occlusions of the covered branches. So we go in detail later on when we take about the anterior corridor artery. And in this overview, there were 5 ischemic events, so that were 3.6%, and no other clinical worsening beside those ischemic events. Now we should take a deeper look at the different territories and different branches, because it's a difference where you place the flow diverter and if it has a consequence or if it don't have a consequence. That the big questions with arising branches and the perforators. So this study here of Mr. Burrows focused on the flow diversion and covering of the ophthalmic artery. And we see here in 64.9%, we had occlusions of the ophthalmic artery. And we had in this study no permanent adverse visual outcomes. That's kind of interesting because it's a high rate of occlusions, and everybody would guess, okay, there's a big, really more or less important artery that is occluded and there are no visual outcomes. That's an interesting point, but we will go later on in detail why this is, or why should be the case in the most bigger branches. Then again, the anterior carotid artery, I showed it in the overview in the first study. So again, we got just one case that represent 3.4% of occlusions, and also there were no clinical symptoms. So that's really not the same thing like in the ophthalmic artery aneurysms, because like we see here, we got a really lower rate of occlusions when we compare it to the ophthalmic artery when it's covered. So when we take a look in other territories, we see here was the question in this study, the patency of the PCOM artery after flow diverting, again with a pipeline embolization device. Most of the studies were run with a pipeline device because it was one of the first and the most popular flow diverters from the beginning on. So the most long-term studies were run with this device. So in this study, they focused on that, and we see again, we got a high rate of occlusions, 53.3%, but no symptoms related to the occlusions again. Okay, that's interesting. And again, we also already discussed it, MCA aneurysms. There should be a discussion if you do endoscopy or clipping. However, when you do flow diversion, you'd have to take into account that you jail a branch, or that you cover branches and perforators if the flow diverter just also covers the M1 segment. So in this multi-analysis from Federico Cagnazzo showed that we had 10% occlusions of the covered branches of the perforators, and 5% were related symptoms, and especially ischemic symptoms. So now a really different story is the flow diversion in the posterior circulation. When we take a look on this, here was the question, how is the risk of ischemic complications after flow diversions in the posterior circulation? And as you see here in this study, 103 branches were covered, so around about 80%. And we see a really, really higher rate of ischemic complications, because 29%, that's 22.5% had ischemic complications. That's a really, really higher rate when we compare that to the anterior circulation. So what was beside that interesting, branch occlusions was not associated with a significant increase in ischemic complications. That don't mean that weren't any complication. We saw it, 22.5% had an ischemic complication, but it seems to be, it doesn't matter if any branch was occluded or not. And that was not the point, that this was the reason for the ischemic complication. But again, I can't really have any data for that, but I think there are more branches and more perforators, like I told in the beginning, that we don't see, so we can't count every perforator and branch that is covered from the flow diverter. So I think an ischemic complication in the most time occurred because of a covering of the branch. But we will also discuss that in the few next slides. So now we see we had side branches that tend to occlude, and we had side branches that tend to be and stay patent. And what's the mechanism behind that? And when we take a look, there's a trend that the bigger branches with good collaterals tend to degree. And like you see here, it's just an example for that. You see the posterior communicating artery. We got a big one before the treatment. You see here the AP run of the basilar trunk. We see a nice collateralization from the posterior circulation, and over the time after placing the flow diverter, the ophthalmic artery disappears later on. And that's the point, because there are good collateralations. You got a lower inflow because of the covered branch, and there's a good collateration, and there is a new balance of the flow dynamics and the reconstitution of that. And so over the time, the not anymore highly used branch degree, and the collaterals getting stronger and take over the part of the blood supply for those territories. That's the concept, and one of the approaches how to explain why the bigger branches tend to degree. And just on the other hand, the terminal branches or the perforators, the small ones, tend to preserve. Like we saw it in the enterocordial artery, we know that there is not a really good collateralization for this artery. And there comes something into the on the topic. It's just this called the suction effect. So you got a terminal artery, and it's also described in fluid dynamic studies that you get a really suction, and that there is the flow in some cases higher than before the flow diversion. So there is a suction, we got a big inflow, and that stays that helps the vessel to stay patent, and there will be no endothelialization at the ostium of this artery. So now we have to just talk a bit about the device, because that's important to understand why in some cases some branches are covered, and maybe it's also an explanation why the posterior circulation is more difficult for flow diversion, and that there are more ischemic events than in the anterior circulation. Because first of all, you have to know two things. The first thing is the porosity, and that the proportion of the open space at the surface of the cylindric device. And you see that here, you see the gray crosses are the struts, and the yellow area is our porosity. Then you need to know the pore density, and this is not only the porosity, that takes also into account the caliber of the struts, because the bigger the struts are, the smaller the area or the free area of the flow diverter is. And that's only the number of metal enclosed, the pores at a square millimeters. So we see here in red then our struts, and that's now the important point, that we don't have to, or we don't tend to use one device for all patients on this, and we have to take this into account and have to think about which device we should use in which location for which patient, because the porosity and the pore density differs in different flow diverters from different vendors. You see here some different vendors. You see the Fred X, you see here HPC 64 and the Derivo here. And that's an important point, that they differ from each other. There were some studies out there that describe that the optimal porosity is about 70%, and you got a pore density of 80 pores per square millimeter, and that should be the perfect match for achieve a good aneurysm occlusion and a low risk of covering branches. On the other hand, just to get an example how this works, when you take this into account, which device you choose, if the porosity is lower and you get a higher pore density, then you got a greater propensity for an aneurysm occlusion. But on the other hand, the risk of branch occlusion is also increased. Here's just a small animation for that. You see here in blue, in the blue crosses are just the struts, and this red dot should be a perforator. And you see here maybe kind of the optimal porosity of 70% and 80 pores. And if you just thicken the struts and to reach a higher porosity, you get also then a change in the pore density. And when you just thicken the struts to get a better or faster occlusion, you also cover smaller branches like this. And that should be an explanation why with different flow diverters in the posterior circulation, maybe the ischemic events are higher because we got smaller perforators, around about 200 to 300 microns, that are really, really smaller than in the anterior circulation. The perforators of the anterior circulation are taller, and that's maybe a reason why you got a worse outcome of flow diversion in the posterior circulation. So I will finish my talk with two cases. We see here just a recent case of our institution. We had a 55-year female patient that showed up and was referred from an outpatient with a PCA stroke on the right side. Everything was okay. We saw the stroke in the right PCA territory, and we just recognized in this MRI run that there is something on the left side at MCA, and also the ACOM just was not that perfect. And we said, okay, just have a look on this. See here also the T2 weighted images. And you see here again, the ACOM complex, it should not look not that smooth as it should be. And so the patient was already back, and we just did an CTA run. And you see here the left side is M2 aneurysm, and also these ugly ACOM complex aneurysm. So what was our plan? First of all, we did flow diversion for sure. Otherwise, I won't show this case. But there were two aneurysms. We start to treat these M2 aneurysm with a flow diverter. You see here just the animation of the 3D run. You see those two aneurysms, also the ACOM complex aneurysm. And again, here's just the static picture of it. We got our ACOM aneurysm and MCA aneurysm. So we placed, that was the pre-treatment angio run. Again, you see those two aneurysms, and just take a good look at the perforators. We got here our lenticular striate perforators and also this frontal branch. And that was the angio run instantly after placing the flow diverter. You see here the shadow of the flow diverter, and you get already afterwards stasis in the aneurysm in the late venous phase. And we didn't touch for sure the ACOM aneurysm in this session because there was no bleeding. So we just treated first the MCA aneurysm, and afterwards the ACOM aneurysm. You see here now the control angio after 8 months, and you see still some stays in these aneurysms. And here you see the 12-month DSA run and the control. You can recognize that the ACOM complex aneurysm is also treated. We treated this one with a control device, so we did an intrasaccular flow disruption, and there is no more filling of the MCA aneurysm. So, but we want to talk about the perforators, and we just compare those two pictures. We see the treatment picture. We see this big frontal branch here, or the bigger frontal branch, and the perforators. And after 12 months, we didn't cover here those perforators, but we covered this frontal branch. And when you take here a look, there was again just a degree of this frontal branch, and also some of these perforators degree here, but especially this frontal branch degrees, but there was no more clinical symptoms, and also this patient got some MRI runs because she had also another neurological deterioration in this PCA territory. That's why he had an MRI run, but there was no new infarctions. Then in the second case, again, an MCA aneurysm, but in the M1 segment, you see the 3D angiogram. We placed there E84 HPC and coated flow diverter, and we really covered the branches like you see it here, and also the perforators. And we got an instant post-MRI after 3 days. You see here the DVI. There was just a small dot right-sided, or small dots here, but that you got also small dots after just diagnostic angio run, but there was no clinical symptoms. So the patient went well and was referred. And also on the flare, you don't see any lesions. Then we got our DSA control. And when we compare them, you got here on the left side our treatment DSA run. Then in the midline, you see the 3 months control, where still the aneurysm had a kind of filling. It was reduced. And afterwards, after 12 months, you see here the aneurysm is cured. You got a smooth remodeling of the parent vessel, and there was no occlusion at all of those perforators and the lenticular striates and these frontal branches. So when we summarize, flow diverter placement is safe in the anterior circulation. We see that also if crunches are covered, we had a low risk for ischemic complications. And when we place a flow diverter in posterior circulation, it's really a different story, because there's a high risk of a major stroke from around about 20%. So we have to take this into account when we want to decide which treatment is the best for the patient, if there are other opportunities. And as I mentioned before, bigger branches with good collaterals tend to degree, and the terminal branches tend to preserve. That just depends on these collaterals and these suction effects of the change fluid dynamics. And we have to remember on these on the porosity and the pore density, because we have to take that into account when we consider the treatment planning, which flow diverter we should use. We should use the fitted flow diverter for this area. So thank you for your attention.
All right, thank you, Roland, for the great presentation. I think one of the major points here, probably for the young neurosurgeons, is actually that the larger branches stay open less, and that the smaller ones, the perforators, that they stay open. Probably most people would have thought it's the other way around, and it's something that the neurosurgeons probably don't think about that much. We will continue right away with our last talk, also because it's on a similar topic, this time from Philippe Dodier from Vienna. He's the deputy head of endovascular surgery there, and he's a trained hybrid neurosurgeon. So he's done a neurosurgery residency and was trained in endovascular surgery. So we're excited for his perspective on flow diverters or aneurysms that have perforators and branches.
Can you hear me?
Yes.
So thank you, Miriam. Thank you, Silvia and Anna, very much for the invitation. I'm really feeling, yes, very humbled and honored to have been asked to, yes, present the third pillar, or the third, let's say, perspective to today's talk, the hybrid neurosurgical perspective. So basically, I have no conflict of interest, but I want really to specify that no device or manufacturer are going to demonstrate the data from, or any kind of recommendation or endorsement. So I'm also very honored that Professor Lawton is here. You can see here one of those editorials. So in the end, what we can summarize from those editorials of the last decades, since 1997, that every 10 years, there's this editorial talking about the future of neurovascular surgery and needing to adapt to the rapidly advancing endovascular technology. And at the same time, this 10-year cycle demonstrates that every few years, something new comes on the market and is being, let's say, deemed and assumed to be better than the previous generation. And indeed, for certain ones, especially the ones who have already long-term data.
Sorry, Felipe, sorry to interrupt. Can you stop sharing and share again your presentation, because we just see black?
Beg your pardon?
Can you?
We are not seeing your slides. Can you stop sharing the screen and then share it again to see if it works?
Okay. Apologize for that. Let's try again. You see it now?
Okay, great now. Thank you.
All right, sorry for that. So again, those editorials and just this 10-year cycle that demonstrates that there's a lot happening on the endovascular manufacturing side. But in the end, what is really important is maybe to have a more balanced approach and discussion of those flow diverter indications. So as Roland just told you, we have this clear concept of especially reconstructing the diseased vessel segment. This is what has really changed the game in the last few years compared to endovascular coiling treatments, that those flow diverters really reconstruct the entire aneurysm-bearing segment. But there's still, nowadays, 2024, many open questions that need, especially from the neurosurgical point of view, need to be addressed. And I'm going to try in the next few slides. So bear with me, and thank you for everyone still staying around. So the first one is, of course, the dual antiplatelet therapy. Until today, there are no international guidelines on how and when to prepare your patients for flow diverter treatments, especially to avoid the thromboembolic complications and the risk of stent thrombosis and stenosis. So how we do it in Vienna for the last few years, after adapting it in 2015, we prepare the patients 7 days before the treatment with aspirin and clopidogrel, and test every single one of them 2 days before admitting them and with the intervention. In many cases, as you can see here, that we've been publishing this 2018, our first 50 cases, we had 45% of clopidogrel non-responders. And we believe that especially in the early years of flow diverter publications and series, this would be one of the explanations why patients did have so many thromboembolic complications and hemorrhagic transformations. So last year we had Gilles Dascarov from the Paris group visiting us and demonstrating and presenting this data from a French comprehensive national survey that demonstrated there is no comprehensive understanding and guideline, not even in France. So basically the duration and the kind of medication changes from center to center. But still what he says is very true. It's the most feared and major complication related to mortality is aneurysm rupture and hemorrhage for most of the people who think about flow diversion. But in the end, the most common complication is still thromboembolism leading to stroke. So there's a lot of discussion ongoing about potential switch from dual antiplatelet therapy to single, to monotherapy. And this has been shown here in this series that has been recently demonstrated that you have in those patient groups 4% rebleeding rate and 8% in-stent thrombosis. So still more than the dual antiplatelet therapy. And this is also why it's still too early for us, especially in Vienna, to change our standard. I'm going to show you our institutional results and what basically this concept of flow diversion. And I also prefer and like to toggle the flow disruption. So as a neurosurgeon, I will, of course, want to also show this to motivate you, every single one, the next time you see an aneurysm that you clip or assist, and you see these thin-walled aneurysms with those turbulences inside the aneurysm that you especially can confirm in the ICG fluorescence. And as Roland just said before, the computational fluid dynamics help us to understand what is going on inside the aneurysm, especially what is going on once you have placed those devices, especially those struts and devices like the flow diverters. So we are completely changing the flow, it's disrupting what is going on inside the sac, and slowly and surely over the next matter of weeks and months, the aneurysm is going to thrombose slowly and shrink and completely disappear. Here, just to demonstrate why also the level of complexity and the complication risk is higher than simple and standard coiling alone. You need so many devices. You need the macro catheter in the neck. You need the intermediate catheter until your skull base. And in the end, you have, of course, to place your micro catheter distally of the aneurysm. Here in Vienna, we like to perform coiling supplemented flow diverter implantation in cases of 1 centimeter of diameter or more. We also use a software to pre or interventionally size the correct device. It helps us a lot to not lose time on the angio suite. And what is extremely important from my point of view, to know and to understand is that until just recently, very recently, the flow diverters were only indicated and received the CE FDA marks only for ICA aneurysms. So this is what they were basically conceived for many, many years. And only just recently, the latest generation that we are using now in Vienna has changed that. The word ICA does not show up anywhere in those documents. But what is very important is that they recommend it should not be used alone as a recommended sole therapy for acutely ruptured aneurysms. I'm going to go back to this later. So about our institutional results from 2018, we had, out of our 468 patients treated between 2010 and 15, 59 aneurysms treated with the first, second, and second generation of the pipeline device. 94% of them were treated inside, of course, the ICA. And what is relevant and interesting that over the time, of course, the deployment issues we saw in the beginning have improved, but still in 26%, the deployment of the device needed to be supplemented by balloon techniques. And we had in very few cases immediate stent migration or delayed stent migration. What you want to see once you apply those flow diverters is this flow changes. If you see them immediately, then you have a very good feeling that after 8 to 12 months, your reconstructed segment is going to completely cure. But not always. And this is why also basis I'm very grateful for what I'm showing and discussing the topic of complex aneurysms and the definition that has been until recently only defined by Heinel and Spätzler. So we tried from the endovascular point of view to adapt this definition and applied it to our aneurysms. And in the end, we could demonstrate that in standard aneurysms, one device was fully enough and sufficient to reconstruct the vessel completely after 1 year. And what we also could demonstrate that in aneurysms of complex morphology, if we saw an immediate significant flow reduction after deploying the stent, we had in the end 100% occlusion rate of those aneurysms. So 95% sufficient aneurysm occlusion rate. This is, I think, what Nima in the first talk referred to. That's in the end, the endovascular and microvascular surgeons have a different understanding of a complete or a successful occlusion rate. It is clear that from the Raymond classification, Raymond 1 and 2 is being deemed sufficiently occluded if you have no reperfusion on the long term. This is why, of course, those endovascular patients need to be followed up more closely than the microvascular patients, I would say. But it's not only about the neuroradiological outcomes, it's especially about the neurological outcomes. And we had no mortality in these patients still until now, and our elective patients, no flow diverter associated mortality. But still, we had complications. I'm going to talk about them also afterwards. But there's one thing that I would like to stress a lot of is the limitations of the devices. They are not a one-size-fits-all approach, especially not if you have different alternatives to that. And we see, especially in the cranial compression syndromes, in the giant and large aneurysms, that the flow diverter treatments has to be controversially discussed. So there are, of course, publications here from Brown and Saline that demonstrate an improvement of those cranial nerve compression effects, the ophthalmopathy, in up to 84% of the cases. But still, the time effect is crucial in those patients. It needs for sure a longer period of time for this aneurysm to shrink and to adapt, and then therefore to decompress the symptoms. So we just published recently this series, one of the largest series internationally, of standard flow bypasses alone, supplemented techniques and parent artery occlusions for those giant aneurysms. So we do not like the terminology of low flow bypass, especially if you just understand that double barrel bypasses can grow over time and even reach 120 milliliters or cc per minute if adequately performed and technically performed. So for us, in the indication of this retrospective series was the cranial nerve compression syndrome, and to assess its long-term effects. And we could demonstrate in those 47 aneurysms, 50% of them giant, that we have a resolution or a marked improvement of those compression syndromes in 84%. So basically underlining and for us also confirming that these bypass supported techniques, and I'm here right now in Athens at the bypass course of Professor Andreou, needs to be a part of our armamentarium also in the future. So there's still open questions in the end, long-term data. So many new devices are coming almost every week on the market, but what about the long-term success and neurological complication rates? So I would say that the PUFs needs to be, especially for us neurosurgeons, one of the studies we need to know, one of the largest long-term series of the pipeline flow diverters. And they demonstrated after a 5-year follow-up a 95% complete occlusion rate. So I would say more than satisfactory, but still 4% mortality across those different centers, predominantly in Europe and the States, and serious device-related events of 5%. So we are far from having this, again, one-size-fits-all approach. We need to, of course, also know our own data to perform the counseling of the patients adequately. So here are our complications of the first series we presented. That's even in the, let's say, very experienced hands, those complications from our point of view based on thromboembolic and especially also medication issues can arise. Again, luckily we did not have any mortality, but those patients had both on the contralateral side of the aneurysm was treated, those ischemic transformation, this hemorrhagic transformation of thromboembolic events, and therefore this needs to be taken into account when you perform the counseling and informed consent of your patients. And just to follow up on what Roland just demonstrated extremely well, the flow diverter is not only impacting the aneurysm itself, it's impacting the entire disease segment. And especially if you have issues and problems to reach the target distal landing point of your device, in this case, being at the level of the M1 and then covering a dominant A1 on the left side. This is a young patient of only 35 years of age, who basically, due to our change and influence of his anatomy, has now a reduced flow. And of course, he has an adequate collateral flow from the contralateral side. But still, what we do not know today is how is this patient going to be 20 or 40 years from now, when, of course, atherosclerotic disease is going to impact him. So we are changing also his long-term statistical chances to maybe having less collateral flow once he gets an ischemic patient, not an aneurysm patient anymore. So we are affecting the patient's anatomy without really knowing and having the possibility to predict how those patients are going to fare over the next course of the next decades. So I would just go briefly just talk about this because Roland did it much better than me. But still, the occlusion rate, the occlusion of relevant side branches and perforators needs to be taken into account when you perform the indication setting of your flow diverters. Here, this Chinese group just demonstrated in the meta-analysis, including 3,800 patients, a high rate of occlusion of over 60% in those ACA aneurysms and 44% of PCOM. So basically, at least confirming the numbers shown by Roland. And one of the, I think, most relevant open questions to date, especially from the neurosurgical perspective, because these are the complications that we need to treat. It doesn't matter if it's our own complications as hybrids or the complications of the endovascular colleagues. Once you are implanting an intraluminal device, a flow diverter, a stent, the patient needs to be loaded at the table. The patient needs to be medicated over the next few weeks, as long as he's also on the ICU, and it's going to have an impact and stark consequences on the treatments of basically simple treatments like EVD, and then of course, then shunting of the patient. So for us, the flow diverter will remain, and I'm speaking just for our center, as a final resort strategy and not a primary strategy. And not only those ruptured cases, but also the small vessels and posterior circulation aneurysms are no first-line strategy indications for flow diversion. And to cite a very, very dear friend and smart guy, just because you can do something doesn't mean you should do it. This is from Nikola Velinov, from Sofia and from the ENS. And this is also why we do not only include those multimodal treatments in our calculations. We also have to include this. The best medical treatment is also a part of our armamentarium. We have to take this into consideration, talking to our patients. So Nima did a perfect job presenting the recommendations. We are right now very closely, hopefully, to having this publication published. It's still under revisions, but we have been assessing out of our 4,715 patients of the last decades, all 661 that were treated conservatively. And these numbers are not going to let's say, be important maybe for the discussion, for the future discussion internationally, but especially for us, as we think that we have and need to know our own data to be really able to assess and counsel our patients adequately, and also to just jump back to the question that was asked to Nima. How do we see the future of training, both of microvascular and so hybrids, endovascular? We need to go to use the new technologies, the 3D printing technologies, in those patient-matched cases, and we have been developing both a microvascular open surgical and also endovascular simulator together with the Department of Medical Physics in Vienna, that are helping us to not only prepare optimally for those patients ahead of entering the EOR or the angio suite, but especially to train the next generation based on objective skill assessments. So I would say that this is maybe the most important line for me, that you have to know your data, your institutional data, your own, in order to really adapt and counsel your patients adequately. Thank you very much for your. Thank you very much.
Thank you, Philippe. Great talk and a very different view from the hybrid point of view. So one of my questions was going to be for the two of you, but from your talk was pretty clear that you basically adhere to the ISO guidelines. But what about you, Roland? What's your algorithm for deciding when to use flow diversion?
So first of all, we just take into account, is it a ruptured aneurysm or is it unruptured aneurysm? So for sure we try not to using flow diverters if we have an ruptured aneurysm, but in unruptured aneurysms also we take into account the age of the patient, and we discuss this every case with our neurosurgeon. So it's an interdisciplinary decision. We don't make it on our own. When we think the best option for this patient is the microsurgical approach, then the clipping is really fine for us. Especially for the MCA bifurcation aneurysms, I think today we're now 50-50, 50% gonna clipped. If it's straightforward, like I mentioned before, we can place an intraluminal flow disruptor in straightforward case, so we do it endovascularly, but placing flow diverter. If it complex aneurysms that should be also not good treated with microsurgical clipping or another endovascular technique, so we go for a flow diverter. So we tend to just orientate to the guidelines, sure.
Okay. So another question that I have for you, for the two of you, Philip already mentioned on it, but uh, all those perforators occlusion that we don't see a translation in the MRI, but do you really think there's no type of translation of those occlusions? Because, for example, when we see with ABMs, you don't see, you think there's nothing going on with that ABM, but when you remove it, you see a patient that changes his academic performance or his behavior. So do you think these occlusions have some type of translation that we are not seeing only on the MRI? And do we need further studies on this?
I think I don't know any data about that, but it doesn't seem like this because we have our patient, they just come for a control DSA about 2, 3, and 4 years, and we don't see a change. But it's just my point of view on this patients. But I think it depends on the location where we place a flow diverter for sure. And I think if there is a big infarct, sure, there should be a change. But it's another thing like in a stroke case where you got an instant occlusion on artery that changes all the thing at once. And if you're doing flow diversion, like I mentioned before, there are different ways how the flow can reconstruct. And I don't think that these territories get a low perfusion because they got a reconstitution over long term. So collaterals build up. And I don't think the blood supply is really bad in those territories, and that's why we don't see really changes in this. But there's an interesting study, I think 4.5 years, it's published in JNS. They just made after flow diversion in 6 and 12-month control in MRI perfusion. And they saw and they published and they said, okay, there is perfusion deficit is a slow one, but there is a perfusion deficit on long term. So I don't know if it's the time or it's just a result of the reconstitution of the flow that there is a perfusion change. And if it's really matter, we don't know what it means that there is a perfusion change. There's no low perfusion, but there is a change in perfusion. And that's why I don't think that are really changes, because you got a long time where the blood flow can reconstitute of that.
Yeah, my concern is that we don't know, as Philip was saying, that how that translates into clinical symptoms in the longer term. I mean, not in 3, 4, 5 years, but in 20, 25, 30 years.
Sure. So we have to study this. It's like in former times when the ISAT study came out and we saw that some patients after the open approach had frontal syndromes, and we didn't recognize that before it. But in the long term, we saw there were a difference in both treatment arms. Sure, we have to take a look on this in the long term.
Maybe one thing that I would like to add is because the data you showed before in those ophthalmic artery aneurysms, where those patients seem to really fare rather fine without any long-term permanent morbidity and complications. But what we have seen is that we do have temporary issues. So especially in patients not very compliant with the medication in one case, another one very young patient with a significant narrowing of his ophthalmic artery. 2 years after treatment, that they develop amaurosis fugax or minor visual deficits that recover very fast, and some just mention it 1 or 2 years later when they come to the outpatient clinic. So I don't think that there is a very big dark number here that is not described, not known. Of course, what we have to look for is permanent morbidity. That's what is a measure of success in the end. But I think that's also very important is for us to assess in those ophthalmic aneurysms, artery aneurysms, to assess the ECA flow in the external carotid angiography lateral projection, because you're sometimes surprised that there are very important collaterals already being performed, and that is going to help you to support if you can or cannot cover the ophthalmic artery.
Yes, That's really an important point. And that's what I want also to show with my talk. You don't have to choose just a flow diverter, say, okay, we got an aneurysm here. It have to be so long, so just place it. So you have to take into account which flow diverter do we take with the porosity and the pore density. You have to really take a look at the already existing collaterals to take just into account, can I just cover those branches, or better don't do it? And that's more than just, okay, just putting in there a flow diverter. That's not the more, it's really more, it's more the decision making before doing the treatment, right? Not just placing a flow diverter, yes or no. So
Okay. There's a question, a very technical question on the chat. So it says, have you had challenges in choosing the size of flow diversion? My experience with the Terumo Fred Frex, especially for aneurysms which require flow diversion less than 5 millimeters, 22 millimeters, which is the least available size.
so if
Yes,
I have
challenge
to
choosing the size of flow
the
diversion.
size, should I answer or do you want to feel?
I'm going to follow you.
Okay, so sure, sometimes we had issues with choosing the right size, but like Philip just mentioned it, we use now just simulation software for choosing the right size, because also the curves that you should take into account, and you can see just more dense structures at the aneurysm neck and more wide structures just distant from the aneurysm neck, and we have to take this in account also. Different devices behave just different. For example, the HPC and the HP64, they foreshorten more than like the Revo or the pipeline. So you have to take this also into account, which flow diverter do you choose. So yes, in some cases we have really, it's hard to choose the right size because sometimes it's foreshortened all the way, but that is why simulation software is really a good innovation picture.
And it's improved significantly now since last 15
Yes.
years. So it's planning the devices now compared to 10 years ago is a completely different story. So they're getting more and more adequate. There are basically unwritten rules of targets, landing zones, especially on the proximal landing points where we want to be, especially in the ICA, in the horizontal segments, and try to avoid the vertical ones, because there you have less control of where really it's going to land with the device. And those softwares, they're not different companies now on the market, are getting more and more closer to the real thing. This is also why those devices have now not only 0.5 millimeter, but sometimes 0.25 millimeter changes between the devices. So they are also getting more adequate and help us to perform these procedures almost as simulated.
Okay.
Right, maybe I can ask one or two questions. Same question as I asked Nima. Do you know of maybe 1-2 large R cities that we should be looking out for that could change what we do in the future, that we should look for the results? And the other question is, there was recently a Delphi consensus in JNS about how to define treatment failure for flow diversion and what to do if that happens, if you're not happy with the obliteration rate after a year or two. And most of the authors said they would put a second flow diverter into it. What is the situation if you have a perforator or a branch that you really need to save? Is that actually an option then?
Okay. First, nothing to your first question. Filippo mentioned it. I think you have to take into account this PUF study. That's really important because you get big data set in the long-term run, and that's really important because it's the most used flow diverter over the world, right? So we have to take a look in that, and also for just taking into account the near future, also all the studies about the intracellular flow disruptors, because I think that will be a big thing in the future for treating aneurysm, because you don't have to be scared about dual antiplatelet therapy and so on, and also in young patients. That's something where you have to take a look on. And the second question was about
And what you do with treatment failure.
with the treatment, yes.
Mm.
So our approach would be also to just place a second flow diverter. That's true. And for sure, in the theory, it could be that you place the flow diverter just a little bit shifted, so you just cover all the areas and you get a pore density or a porosity of maybe 0, don't know. So like a covered stand. But in reality, there are some studies out there that showed that there is no really an increased risk of perforator occlusions. So it seems to we don't know that much about this topic. So there's many stuff to study for us. But the studies that are out now show that there is no increased risk of infarctions after placing second flow diverter.
Absolutely. I agree 100%. So no RCT, at least as far as I know. It's if Nima is, if there's someone in Europe who should know, then it's him. I did not respond this is a question positively. But of course, post trial, it's not a randomized control, but still it's the best data available so far. And they're still assessing, so we're going to have soon the 10-year and 15-year results. So we have going to be looking out for that. And about 2 devices, yes, that's why although we had a look at our data and then presented this immediate disruption score, because we saw that 1 or 2 devices may sometimes make the difference. And sometimes you might need it during the very first procedure and spare your patients and narcosis 1 year after, and then you can just rely on the diagnostic imaging tool. So in this case, yes, it's a topic that is still not answered. But I think for especially for complex aneurysms, where you do not see any kind of effect of your first flow diverter, a second one will have a significant impact on the long-term occlusion rate.
All right, thanks.
And you have give the aneurysm and the flow diverter time. Also in these giant aneurysms, you don't have to be scared if there after 6 months is no occlusion. You have to give them more time. That's the most important point of it.
Well, you're influencing it, no? By the decision making when you are going to reduce and stop with the medication.
Okay. Okay, thank you very much. I think we need to wrap it up because we are way over our time. Thank you very much to our panelists for their outstanding talks. And thank you very much to everybody who participated with their questions and comments. It was a great webinar. Thank you all for your participation.
Thank you very much.
Thank you for the
Thank you. Have a
invitation.
great evening.
Bye-bye.
Thank you. Bye.